good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Abha Nagral from Mumbai, and she's going to lecture us on immunosuppression and hepatitis B and hepatitis C. This webinar is brought to you by Mumbai Hematology Group, supported by RPG Life Sciences Limited, and managed by Perfect Square. I thank Mr. Sudhir Ambekar and the team RPG Life Sciences, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Ganesh Jeshetwar from Hyderabad, our guest speaker for the day, Dr. Abha Nagral from Mumbai, all our discussants who are themselves very eminent hematologists and hepatologists, and you participants for spending your Sunday morning, afternoon, and evening. Let me give a flavor of our next weekend activities. Next Saturday, Sunday, that is on 20th of January, Saturday, we have a webinar on new WHO classification of lymphomas from 7 p.m. onwards by Professor Naresh Kikri from Washington, US. And the following day, that is Sunday, 21st of January 2024, from 11:30 a.m. IST onwards, we have a webinar on an update on aplastic anemia non-transplant management by Dr. Austin Kulasekararaj from London, UK. Now it's time to introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Akshay Mandloy from Mumbai, Dr. Arun V.A. from INHS Aswini Kolaba, Mumbai, Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, HIMS, Dehradun, Dr. Girish Balikai from SDM Medical College Hospital, Dharwad, Dr. Gopinathan M. from MGM Healthcare, Chennai, Dr. Hamza Dalal from Fortis Hospital, Mulund, Mumbai, Dr. Neemya Thanda from North Okkalapa General Hospital, Myanmar, Colonel Dr. Kundan Mishra from Command Hospital, Lucknow, Dr. Manoj Toshniwal from SIDCO, Aurangabad, Dr. Pujita Bai Reddy from Care Hospitals, Hyderabad, Dr. Rajesh Patil from Hemocare Hematology Center and Bethany Hospital, Thane, Mumbai, Dr. Rajni Priya Yedla from Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, Dr. Sandeep Nemani from Sri Siddhivinayak Ganpati Cancer Hospital, Miraj, Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow, Dr. Siddhesh Kalantri from Blood Care Hematology Clinic, Nashik, Dr. Sudhakar Sharma from Lokmanya Tilak Municipal Medical College and Hospital, Science, Mumbai, Dr. Yi Mon Tan from North Okkalapa General and Teaching Hospital, Myanmar. Now it's the time to introduce our very special guest for the day. We have with us nobody else but Dr. Ganesh Jeshetwar from Hyderabad. We all know him very well, and he doesn't require any introduction. But it's my formal duty to introduce Dr. Ganesh Jeshetwar from Hyderabad. Dr. Ganesh Jeshetwar is MBBS MD from Mumbai, DM Clinical Hematology, postdoctoral fellowship in BMT from TMC, fellowship in leukemia and BMT from UBC Canada, lead consultant and head at Department of Hematology and BMT, Yashoda Hospital, Hyderabad. It's our pleasure to welcome him to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Ganesh Jeshetwar.
Thank you so much, Dr. Amit, for that kind introduction. Good morning, everyone. As we rejoice the festive season of harvest and new beginning, I wish all of you, all the eminent clinicians, students, and senior consultants on this August virtual platform of MHG, a harvest of happiness, health, and prosperity this Makar Sankranti. And it is very heartening to see that over last more than 2.5 years or so, to see the MHG Mumbai Hematology Group led by Dr. M.B. Agrawal, sir, this famous Sunday webinars taking these new heights and peaks across the educational forum. I remember during the COVID times, COVID was a good and bad time for most of us. So one of the ideas, looking at various other virtual platforms, I remember I discussing with Professor M.B. Agarwal, sir, about such an activity, particularly on a Sunday where everybody is at their leisure time. And sir has taken this concept and this idea to such a wonderful educational platform that it becomes an encyclopedia of ready-made referrals, ready-made database of experts, giants, doyens of hematology, speaking on various aspects of and comprehensive hematology, and not just the world-renowned authorities speaking on hematology, but the panel discussion bringing out the real-life practical issues relevant to each and every field. Again, I would like to express my immense gratitude and admiration that Mumbai Hematology Group, under the able leadership of Professor Embagal Agrawal sir, has provided hematology education in India in the realm of knowledge and learning. MHG's unwavering support shines a beacon of hope for thousands and thousands of not just students, but juniors and seniors in the field alike. It's really heartening to see. And I must say, with a short practice of 12 years in the field of hematology, bone marrow transplant, when I look back into the evolution of hematology in just this short period of 12 years, it's very exciting. Looking at this short experience, I must say we are living in the most exciting phase of hematology, hemato-oncology, and bone marrow transplant. Just 10 years back, the bone marrow transplant or hemato-oncology success was not as high as it is today, and it is each day, each month, and each year the progress is so immense that the outcomes across the vast hematological spectrums are immensely improving. So, it's like, and this rapidly evolving field, our life is like a barcode life. Everything in life comes with a barcode nowadays. The life science and the technology has evolved so much. And I must say, this MHG based webinars, when you look back into the, just Google search for any topic, the highest quoted, highest referenced, and highest viewed are the talks, eminent talks on the MHG database library. So, and coming to today's topic, we may see, the another important aspect apart from the innovation in hematology, the novel interventions, the therapeutics, and the newer technologies. One of the evolving, another thing which I had seen in the field of hematology is the understanding and realization of necessity of teamwork. I remember 12 years back as a hematologist, hemato-oncologist, we used to work alone. Now we have a team of, immensely valuable, insightful consultants from across specialties, like particularly of note are infectious diseases, pulmonology, gastroenterology, which makes the management of vast hematological spectrum very easy as a collaborative teamwork. And in this context, we have a very important topic. As we know, the era of immunotherapies, CAR T cell therapies, advanced complex bone marrow transplant, like ever shooting numbers haploidentical transplants, thereby intensifying the immunosuppression. We are becoming more and more wiser and smarter in terms of management of various blood disorders and blood cancers. Rather than relying on more and more intensive chemotherapy, we are, taking advantage of these novel interventions, immunotherapies, to improve, to optimize the outcomes of various hematological disorders, including blood cancers. And by doing so, lot of non-hematological issues, in particular the infectious complications, the organ toxicities, a different set of organ toxicities is evolving. And in this context, this topic of today's discussion, hepatitis B and C in the immunocompromised patients in relevance to hemato-oncological therapies, is of huge importance. So, partnering with such specialties, collaborating is really rewarding. I remember whenever we, I am sure my experience will be echoed by many of our eminent colleagues on this August platform. Whenever we share our case scenarios across various platforms, the common, appreciation note from most of the seniors in the field is this kind of care reflects the collaborative teamwork at your hospital, at your workplace. And that's the importance of such kind of collaborative teamwork with varied specialties relevant to our management is very, very important. So I would like to conclude with the message to all the budding hematologists on this August virtual platform: embrace the challenges, celebrate breakthroughs, and remember, each topic, each subspecialty arena of hematology has the potential to weave a story of resilience and hope. As we explore the realm of hematology, let curiosity guide our pursuit of knowledge, and let compassion be our compass in patient care. Together, let us elevate the symphony of healing with innovation, collaboration, and with wisdom, learning through these August virtual platforms like Mumbai Hematology Group's Sunday webinar. And it's my honor and privilege to be invited as chief guest at such a student phase. And I'm really grateful to Professor M.B. Agrawal sir for, inspiring, motivating hundreds and thousands of students like me across our hematology, society from our country. Thank you so much. And I wish this August webinar a grand success.
Thank you so much, Dr. Ganesh Shashwatar, for that very kind words of wisdom. And your words really will add to the meaning and will add benefit to all our youngsters, budding hematologists, residents, and fellows. Thank you so much for being with us today as our chief guest. Thanks a lot. Now it's the time to introduce our guest speaker for the day. We have with us Dr. Abha Nagral from Mumbai. Dr. Abha Nagral ma'am is Director at Department of Gastroenterology, Justlock Hospital and Research Center. She is hepatologist and liver transplant physician at Apollo Hospital, Navi Mumbai, and visiting hepatologist and liver transplant physician at BJ Wadia Hospital for Children, Mumbai. She obtained her training UG, PG, and DNB gastroenterology from SET-GS Medical College in KM Hospital, Mumbai. She also obtained her hepatology and liver transplantation fellowship from Mayo Clinic, USA, and Royal Free Hospital, UK. She is a founding trustee for Children's Liver Foundation NGO, helping families of children with liver disease and creating awareness. She is a chairperson of South Asian Association for Study of Liver Women's Forum, chairperson Liver Committee for Zonal Transplantation Committee, Mumbai, past president and secretary, Maharashtra chapter of Indian Society of Gastroenterology. She has over 115 publications on PubMed with several textbook chapters, including API textbook of medicine. Her areas of interest include Wilson's disease, Guillain-related liver injury, Gaucher's disease, inherited liver diseases in adults, cirrhosis, liver transplantation, and fatty liver in children. And today she is with us and she's going to lecture us on immunosuppression and hepatitis B and hepatitis C. Well, thank you so much. Over to you, Dr. Abha Nagral, ma'am.
Thank you, Dr. Khurana. And at the outset, I'd like to thank the Mumbai Hematology Group. I have spoken here once before, and it was really an enlightening experience. And I must say that, as Dr. Ganesh mentioned, there is so much of overlap and interaction between hematology and hepatology. And I remember over a decade ago, we had a meeting where we talked about the interface between hematology and hepatology. And I can just think that it is time to have another such meeting because there's so much which has evolved both in hematology and hepatology over the years. So this particular topic is a challenging problem to treat and also a challenging topic to talk about. I've tried and simplified it as much as possible. And I think I can just say that try and focus on the slides. We have enough time for discussion, and we'll be happy to do that at the end of the meeting of my talk. Let me start sharing my slide.
Yes.
Can you see my slides?
Yes, ma'am.
Okay. So certain key facts about hepatitis B infection. We know that it can cause both acute and chronic disease. It is primarily transmitted from the mother to the child, especially at the time of birth and delivery. It can also be transmitted in early childhood, what is known as horizontal transmission from one child to another in the family without the mother being infected. It can be through contact with blood or other body fluids, during sex with an infected partner, and more commonly with unsafe injections and exposures to sharp instruments, which is not uncommon, especially dental work in our country. It's very much controllable with oral drugs, though we cannot cure it in majority of patients. By cure, we mean getting rid of the HBsAg. And it is highly preventable with vaccines which are safe, available, and effective. Now, in 2019, the WHO estimated there are about 269 million people who live with chronic hepatitis B in the world, with about 1.5 new infections every year. So it's a huge burden and a large number, 820,000 deaths every year from cirrhosis and HCC. In India, the prevalence is about 3 to 4.2% with over 40 million hepatitis B carriers. Now, if you look at this global map, you can see that there are certain areas like Africa, with West Africa having a very high incidence, China, Southeast Asia having an extremely high prevalence of hepatitis B. India is somewhere in the intermediate zone. Now, how does hepatitis B actually come into the cell, come into the hepatocyte and cause damage? So here you have a hepatitis B virion. This is the hepatocyte and this is the nucleus of the hepatocyte. This virion, through receptors on the hepatocyte, gets engulfed into the cytoplasm by a process of endocytosis. In the cytoplasm, the RNA is in the form of what is called relaxed circular DNA, not RNA, sorry, DNA. And this DNA is irregular, not very well repaired, has gaps in it. Now the host DNA, the host decides to treat this viral DNA as its own and repairs it. So you in turn get what is called closed covalently closed circular DNA or cccDNA as we call it. Now the important thing is that this functions like a host DNA and does not get recognized as foreign by the host DNA. So it has a free go and this cccDNA gets converted into RNA, which starts making more copies of cccDNA. Now these copies of cccDNA in turn produce proteins and antigens, and you have the whole virion here, which gets secreted out of the hepatocytes to infect other hepatocytes in the body. So this is how the transmission, or this is how the propagation of hepatitis B virus occurs from one hepatocyte to another. And the importance here is that this cccDNA is actually going to remain in the cell for a long, long time, even when there's a complete clearance of the serology of the virus, which means that a patient has been exposed to HBsAg, develops acute hepatitis or chronic hepatitis, may at some stage clear the HBsAg, but the cccDNA is going to persist in the nucleus of the hepatocyte. And it is this cccDNA which is responsible for reactivation in the future whenever the immunity of the body goes down. Now, who are the people who are at risk? Those who receive immunosuppressive therapy are at a risk of reactivation and flare, and I'll explain these terms. And therefore, in patients with high risk factors, there is a need for closely monitoring serum ALT and DNA to diagnose reactivation early. Now, this is the natural history of hepatitis B infection. So you have a patient who is either on chemotherapy or steroids or any other immunosuppressive drug. So what happens is that the HBV DNA starts increasing and the virus starts multiplying. So there's a high load of hepatitis B viral DNA because the immunity is suppressed. Now, as the chemotherapy is stopped or the steroids are stopped, there is a recovery of the immunity, what is called immune rebound. Now, we know that when the ALT goes up in an hepatitis B infection, what is exactly happening? It is the attack of the immune cells on the hepatocytes, which contain the virus. And this attack causes necrosis and inflammation and rise in ALT. So the higher the ALT, the higher is the immune response of the individual in causing damage. So when there is immune rebound, the ALT, which was otherwise normal, now starts going up. And in fact, the DNA is coming down. And this can lead to an acute hepatitis, which may recover, or the hepatitis B may persist, causing chronic hepatitis or acute liver failure or cirrhosis and death. So this is the natural history of hepatitis B infection. So important to note that the infection gets manifest after withdrawal of immunosuppression in any form when the immunity is coming back. And that is the period which we need to be very alert. Now, just to explain some basic serological nomenclature for hepatitis B. So, hepatitis B surface antigen is the antigen which tells you that the person is infected. It may be acute or chronic. So, just presence of HBsAg does not tell you whether it's an acute infection or a chronic infection. Now, if HBsAg is present for more than 6 months, it becomes a chronic infection. And it is almost always associated with the antibody to the core antigen. Now, this is an IgG antibody. We know that IgG implies chronic or past infection, whereas IgM implies recent or acute infection. So for you to say it's a chronic infection, you need both hepatitis B antigen, surface antigen, and the anticore IgG antibody. Now, when you have only the anticore IgG antibody without the surface antigen, it tells you that the patient has been exposed to hepatitis B in the past, but has now resolved. So he's HBsAg negative, but how do you know that he's had past infection? He'll be core IgG positive. Now, when you have, we've spoken of core antibody and HBsAg, this has come again. When you have anti-HBc IgM positive, it's usually an acute infection, but remember, it could be a reactivation of a chronic infection. So many times patient comes to you, and this is what people must have experienced as hematologists. We were often called, I remember decades ago, we were called to see patients who had received chemotherapy, and they came with flare or acute hepatitic kind of picture, not known to have hepatitis B, and they had IgMs positive. Now, just because IgM is positive does not always imply acute. Many of these could be reactivation. Anti-HBs is the antibody which all of us need to test as physicians to see whether we are protected against hepatitis B. So typically, anti-HBs means you're protected, you're immune, and this comes after taking the vaccine. We need titers of more than 10. And immunocompromised patients need titers more than 100. So they need to be vaccinated if the titers are lower or it's absent. E antigen correlates with the replication and infectivity, but in those with what we call the pre-core mutation, the E antigen may be absent or undetectable. Antibody to E antigen, which is anti-HBe, implies low titers of hepatitis B. Again, the exception here is if the person has a pre-core mutation, then the anti-HBe will be associated with high titers of viral DNA. This is just a diagrammatic representation of what I spoke before. So when there is chemotherapy going on, these are the hepatocytes with the virus. The blue is the virus, hepatocytes infected with the virus. The chemotherapy is suppressing the immune cells, the CD4, the natural killer, the CD8 cells, because of which there is active viral replication. So there is increased HBV DNA. ALT remains the same. The moment there is a gap between the cycles, or you stop the cycle waiting for the next cycle, in this intercycle period, the HBV DNA, the immunity comes back, starts attacking the viral virions here, and you can see that the DNA goes down, but because of the attack of the immune cells on the hepatocytes containing the viruses, there's necrosis and inflammation causing ALT to go up. And then finally, when the recovery occurs, both these come to a plateau, the DNA and the ALT. So this is exactly what happens when a person is given immunotherapy, or chemotherapy rather. So what exactly is reactivation? What does this term mean? So remember, when we talk of reactivation alone, we are just talking of the viral DNA. We are not talking of the enzymes. Now, this is often asymptomatic. So patient is not going to have symptoms. And what it means is if the patient has a detectable DNA, there is an increase 10 to 100-fold after, because of reactivation after chemotherapy. Now, if there is a patient who has never had a detectable virus and now has a viral load of more than 20,000 IU per ml, then also this is considered as HBV reactivation. There is another situation which is called HBV reactivation, which is called seroversion. Should be seroversion, reversion. So we have seroconversion. So HBs antigen, which is negative, becomes anti-HBC positive, becomes HBs antigen negative, anticore positive, which means he's been exposed before but does not have a chronic hepatitis B, at least on the markers, now becomes HBsAg positive. So it's called seroreversion. This is a term which we don't use often, but this is also considered as a HBV reactivation. Now, what are the factors? So you have viral factors, host factors, and the medication-related factors which can cause reactivation. As far as the viral factors are concerned, the higher the HBV DNA, higher is the chance of reactivation. The person is E antigen positive. As I said, E antigen implies active viral replication. So E antigen positive status also implies that the patient has a higher chance of reactivation, and certain mutations have been associated with more reactivation. If there is a co-infection with hepatitis C, then the reactivation chances of hepatitis B are higher. Luckily, we don't have hepatitis D in India. Now, if there's a chronic infection where both surface antigen and the core are positive, this will have a higher risk of reactivation compared to a resolved infection where only the core is positive, but the HBsAg has become negative. Now, we know that even in a resolved infection, surface antigen negative, but core positive, the person can reactivate, but the chances are lesser than if both are positive. And there are host factors. Older age, male sex, presence of cirrhosis increase the risk of hepatitis B reactivation. Now, coming to treatment, how does that impact on reactivation? So if you have a malignancy, solid tumors or hematologic tumors, and these patients are either undergoing chemotherapy or chemoradiation and even chemoembolization for hepatocellular carcinoma, there is a risk of reactivation. Any autoimmune disorder where one has to use various immunosuppressive drugs like rheumatological disease, IBD, dermatological disease, there is a risk of reactivation. Solid organ and hematopoietic stem cell transplant have a risk of reactivation. Now, there was a systematic review looking at patients receiving chemotherapy for solid tumors, and they found that the risk when HBsAg was positive was 4 to 68%, but in a resolved infection, that is just anticore positive, but surface antigen negative, the reactivation risk was there, but significantly lower as 0.3 to 9%. Now, this is an important point. If you are using any chemotherapeutic regimen with glucocorticoids, like you would use R-CHOP, etc., the replication increases significantly. It is because there's a glucocorticoid responsive element in the HBV genome that stimulates viral replication. Now, despite the increase in viral replication, I have showed you in my previous diagram that the liver enzymes actually come down. And the opposite occurs when the glucocorticoids or any chemo for that matter is withdrawn. The viral replication declines, the immune cells start attacking the liver, and the liver enzymes go up. And the peak rise in aminotransferases typically occurs 4 to 6 weeks after withdrawal of the immunosuppressive regime. So that was reactivation, where we are purely talking of an increase in the hepatitis B viral DNA. How is this different from flare? Now, reactivation may be associated with a flare. Now, what is flare? The flare is that basically there is an increase in aminotransferase levels with or without clinical signs of hepatitis. So there is a rise which is more than 3 times baseline or more than 2 times upper limit of normal. The severe flares, it could just be a flare where there is just a rise in aminotransferases without any symptoms. Severe flares are where you have obvious jaundice, hepatic decompensation, and even death and liver failure. Those who have underlying cirrhosis obviously would have poorer outcomes. In up to 25 to 50% the flare could be severe, and the risk is more in patients with hematologic malignancies or patients receiving Ritux-based chemotherapy. Now, as I mentioned, the flares are often seen in gaps between the cycles, often after the first 2 or 3 cycles, when the immune system is recovering more. The viral load, now this is important. It's a flare, but your viral load may be low because, as we said again, that the flare is because of the immunity. The immune system is actually suppressing the virus. So you may have a low or undetectable DNA when a patient is having a flare, and there it will be difficult to confirm that this is a hepatitis B reactivation. Now, severe flares will have the IgM anti-HBC positive. So as I mentioned, this is the antibody we use for diagnosing acute infection, but in severe flares with reactivation, this antibody can be positive, and these often get misdiagnosed as acute hepatitis B. And this especially happens when your viral load is coming down. So you do not realize that this patient actually had a chronic hepatitis B, but now is not being actually detected. So this can be tricky, but we rarely actually use IgM in clinical practice because we go by DNAs and we go by the liver function test. Now, important thing is that when you have very high enzymes, the alpha fetoprotein can also go up to more than 5,000 also. And this should not be interpreted as presence of an HCC. And we'll see that as the viral load and the ALTs come down, the AFP also comes down. Now, it is important in these patients to closely monitor not only LFT, and this is a very important point, but an INR. Unfortunately, most of our labs do not include INR or prothrombin time as a test, as a liver function test. And unless it is asked for, it doesn't get done. And this is the most important test which will tell you about the prognosis of the liver problem. So if the INR is high, this is a patient who is going to go into liver failure, and the patient should be referred to a transplant center. However, the paradox is that it may not always be feasible to do a transplant in a patient who has an active malignancy which has not been treated. There are different guidelines for transplants in different malignancies, and we'll not really go into that. But this is something to be borne in mind, the importance of the prothrombin time. Now, what is a DD of a flare? As I said, acute hepatitis B. It could also be an E antigen seroconversion. Now, in the natural history of the disease, the E antigen slowly wears off and the anti-HBe becomes positive. When this seroconversion is happening, this is seroconversion. Earlier we talked about seroreversion. That was different. When this seroconversion is happening, there is a flare. And so when you are having a flare because of a the DNA going up because of chemotherapy being stopped, you need to be sure that it is not the E antigen seroconversion to anti-HBe which is causing the flare. And this may be associated with the E antigen clearance, though it takes many years for that to happen. And it may be actually happening at that very time when you're testing the patient. Now, what are the other differential? It could be any other virus. Hepatitis A, E can cause enzymes to go up. Drugs, which are not uncommonly used, which are hepatotoxic during chemotherapy, antibiotics, especially in transplant, we see so many antibiotics, especially the antifungals causing so much of DILI or drug-induced liver injury. And of course, do not forget complementary and alternative medications. We are seeing more and more cases of what is now described as HILI or herb-induced liver injury. And I think in any patient with unexplained high LFTs, for us, we always now try to find out or elicit a history of CAM. Not easy. Patients do not come out with it. They do not consider these herbs as drugs. And unless positively asked for, they may not volunteer this information. So now talking of the important things, and I think these are important slides for rheumatologists as to what is the reactivation risk for various conditions, and which are these high-risk patients which need to be prophylaxed with antivirals, and which are the patients where one could wait and watch. So if you have a patient, and this is a nice table given by UpToDate, where they have classified patients into very high risk, moderate risk, low risk, and very low risk, depending upon, and very high risk is more than 20% rate of reactivation, and it keeps going down the line. Now, this is important. If naturally, if one was to think about it, if you have surface antigen positive, the risk will be much higher versus just an anti-core positive. So that is the first thing. So presence of surface antigen and the core in a patient who's receiving anti-CD20 therapy or a hematopoietic stem cell transplant is at the very high risk of developing reactivation. Again, both these positive and the patient receiving steroids of more than 20 milligram prednisolone for at least 4 weeks, or drugs such as doxorubicin and epirubicin, or an anti-CD252 agent, CD52 agent, are at a high risk with a 11 to 20% risk of reactivation. Now, again, those who are both positive and are on cytotoxic chemotherapy without steroids or anti-TNF therapy or integrin inhibitors or TK inhibitors or any organ transplant recipients, solid organ transplant recipients would be at a moderate risk of developing reactivation. But if you have a patient who is surface antigen negative but only core positive, then the anti-CD20 therapy or hematopoietic stem cell transplant risks become moderate versus the very high risk which you see if the HBsAg is positive. Now, rituximab, how does it cause HBV reactivation? It induces CD4 lymphopenia. It affects B cell depletion or immune globulin production, and also induces a change. So it affects both CD4 and CD8. And we know CD8 cells are the cells which cause direct cytotoxic effect on the hepatocytes which are infected with the virus. Now, once the treatment is stopped, the CD8 positive T cell recovers and the cells then are targeted, the cells especially which contain hepatitis B, and that can cause great immune rise in immunity after stopping the retux, and often a liver failure, which we have seen in the past and we missed often because the anti-core would not be done in the past and only the surface antigen was being done as a routine. Now, there are low risk and very low risk patients for reactivation who do not merit prophylaxis with antivirals. So here the risk of, again, both B surface antigen and core positive, if the patient is on methotrexate or AZA or a low dose of steroids, then the risk is low. And in a patient who has a resolved infection with surface antigen becoming negative but just core positivity, then again, if they are on high-dose steroids or anti-CD52 drugs, then the risk becomes low because here the surface antigen is negative. Very low risk is again in those who are just core positive and on cytotoxic chemotherapy without steroids, anti-TNF therapy, and methotrexate or AZA. So if you were to just summarize this, the risks go up with surface antigen positivity, with CD20 and hematopoietic stem cell transplant, with high-dose steroids, more than 20 milligram for more than 4 weeks, and for drugs such as epirubicin and doxorubicin. These are the high-risk ones. And in all these, starting from moderate risk to high risk to very high risk, patients need to be given antiviral therapy the moment the hepatitis B virus is diagnosed. Now, there's another caveat here that if the patient has a viral load which is very high, if it is possible to wait, one should try and wait till the viral load comes down to 3 log and then start therapy. But this is not always possible in real practice. Now, coming to solid tumor chemotherapy, again here, this was a large meta-analysis of 16 studies, looked at 774 HBsAg positive patient who received chemoprophylaxis, and it was found that the reactivation was reduced by 90% in those who got the prophylaxis, and there was no significant reduction in acute liver failure or death. So the chronic hepatitis or the reactivation risk actually came down, but if somebody was to go into acute liver failure, that risk did not come down. And really, there are not many long-term studies which look at these risks. There are just case series and case reports which are looking at what happens on antiviral therapy in those who are at high risk and given given the therapy. Now, when to initiate antiviral therapy in terms of the timing? As I said, in all moderate to high risk, those who are on immunosuppression. Now, how much before one should initiate is not really defined, but as early as possible, preferably with a low viral load to less than 3 log. But as I said, this is not always possible. And then one has to weigh the risks and benefits of waiting on starting your immunosuppressive treatment versus not starting, depending on how aggressive the underlying malignancy is. Now, those who have a low risk or a very low risk of hepatitis B reactivation, the recommendation is not to start them on antiviral therapy. There are no studies on preventive therapy in these patients. And whenever it is not possible to closely monitor these patients need to be monitored with the viral load and the ALTs. But whenever it's not possible, it is better to err on the side of giving prophylaxis than not giving prophylaxis. And of course, you have our standard hepatitis B patients who meet criteria. So you have a hepatitis B patient, for example, he's E antigen positive chronic Hep B with a viral load of more than 20,000 and ALT more than 2 times. He will need treatment irrespective. This is standard criteria for treatment. And the one who's anti-HBe positive, we need a viral load of more than 2,000 with ALT more than 2 times to treat these patients. So this is what we follow in general. So if you have a patient on immunosuppressives with meeting these criteria, they will need treatment irrespective of the risk. What about NHL? And most data of HBV reactivation comes in patients who are receiving R-CHOP for NHL. Most data available is for lamivudine. And there have been 2 trials. One is an RCT and one was a retrospective trial of R-CHOP with large number of patients by the Asia Lymphoma Study Group, where they found that those who received LAM had a reactivation rate of 13% versus 0 in those who received entecavir, and similarly 6% in entecavir and 39% with lamivudine. Now, entecavir is better than lamivudine, so we do not use lamivudine anymore. The most data is with lamivudine because it is the oldest drug, which was oldest antiviral drug which was used. Now, right now, the drug which we often use is tenofovir, both salts, and we presume that tenofovir has the best efficacy as of now. It also has the least resistance. So both entecavir and tenofovir are used, though tenofovir has not really been tested in these trials, and it is presumed that it works because of its overall efficacy and safety and least resistance. So as I said, the data is less. Immunotherapy, now, if the patient develops a flare, what do? Should you continue immunosuppressive therapy or not? If it's a mild flare, continue the therapy, especially if the underlying condition, malignancy that you're treating is life-threatening or severe. But if it's a moderate or a severe flare, then it may be worthwhile temporarily stopping the immunosuppression or cancer chemotherapy until the HBV DNA and ALT levels start coming down significantly. Again, this is something which one will have to balance out, and there is no hard and fast rule over here, but just to know that you need to monitor the DNA in these patients very closely. And depending on the severity, because the patient may not die of his malignancy or the transplant, but may die of the flare. So that is a call one needs to take with a multidisciplinary team. How long does one treat? It will depend on the type of immunosuppressive therapy, baseline DNA, and what is the underlying liver disease. Now, if you have most of the therapies, you would treat for at least 6 months after withdrawal of the immunosuppression. I think that's important. So because as I showed, the problem comes after you stop the chemotherapy. So after you have stopped, you continue it for 6 more months. So you start at the beginning of your immunosuppression or chemotherapy, and then after you've stopped it, for another 6 months, the therapy needs to be continued for most patients. But if somebody is actually getting CD20 agents where the risk of reactivation is very high, you'll wait at least a year. And then, because there's a lag in recovery of B cell function in these patients, and then consider stopping antiviral therapy. Any patient, this is easy, any patient with solid organ transplant or hematopoietic stem cell transplant will need lifelong antiviral therapy. Now, switching gears and talking about hepatitis C, there's not as much written about hepatitis C, and it is not such a big problem with very effective drugs now available. But nevertheless, I'm covering this topic. So we know that hepatitis C causes both acute and chronic hepatitis. Severity could be very mild, asymptomatic to a life-threatening illness, including liver cirrhosis and hepatocellular carcinoma. We know it's a blood-borne virus, was discovered and discovered in around 1989, 1990. Most of the infections which we see in India are through blood transfusions or unsafe injection practices, unsafe healthcare, not using disposable needles, dental work, unscreened blood transfusions, injection drug use, and sexual practices that have led to exposure. The prevalence in India is lower than hepatitis B, which is around 3 to 4%. This is 0.5 to 1.5%. And the highest which we have seen in India is in Northeast and populations of Punjab, where the IV drug problem is big. If you remember the movie Udta Punjab, it was all on this. So it's a huge problem in Punjab from IV drug abuse, and that is a cause of hepatitis C. Unlike the hepatitis C, which we see in Western India, where it's mainly through patients who give history of blood transfusions in the past. Now, the whole paradigm shift in management has come with the discovery of direct-acting antiviral agents, or the DAAs, which were available from 2016. And we luckily had the generic forms available, and our drugs are much cheaper than what they are abroad. And therefore, access is not so difficult in India. Now, so these have made a big difference because more than 95% of patients who get these drugs are treated and can become HCV RNA negative. However, there is no effective vaccine as yet against hepatitis C. Now, if you are to look at the global prevalence of hepatitis C, again, you can see that in Russia, Eastern Europe, and Mongolia, these are the countries, Pakistan, where the prevalence is more than 3%. And globally, about 58 million people are affected. Again, like Hep B, about 1.5 million new infections occurring every year. And we also see a fair number of children and adolescents with hepatitis C, around 3.2 million in the world, as per the 2019 reports. Now, this I'll not go into great detail, but this is what the our society, which is the American Association for Study of Liver Disease in 2021, recommended for patients who underwent transplantation for all solid organs and had hepatitis C positive. So invariably, if somebody is not being treated and undergoes a transplant, the patient will develop hepatitis C post-transplant. The treatment now, it is available with the interferons which were being used in the past. One could not treat these patients after transplant. But these drugs are easily treated, used for patients post-transplant, and they should be started after 3 months after transplant, once the patient's immunosuppression and everything gets standardized. Now, the simplest, now it's become very simple. When we earlier spoke of these antiviral drugs, there was a long list of drugs. Now we have what is called pan-genotypic drugs. So we do not now bother to check the genotype. We start everybody on sofosbuvir and velpatasvir. Unfortunately, this is available and is given for 12 weeks. Now, if the patient has decompensated cirrhosis, then in addition to these, we add ribavirin, or if ribavirin cannot be given, then we prolong the treatment by 24 weeks. Now, there's also a situation where you may have a patient where you're considering transplant. The donor is hepatitis C antibody positive, RNA positive, and the recipient is RNA negative. Now, can this be used for solid organs? This is being used because there's a shortage of organs, and this hepatitis C infection is very easily treatable. However, one needs to be sure that rigorous informed consent is obtained and there should be access to the antiviral therapy. the RNA positive liver grafts cannot be used. This is as far as liver transplants are concerned. So if the donor is positive, but has significant fibrosis, obviously you can't use that liver. And treatment of hepatitis C infection in HCV RNA recipients is exactly the same. So you will treat them exactly for 12 weeks like you would treat anybody else. And one may consider starting the antivirals before transplant if you know the donor is positive. Now, what about hepatitis C reactivation? Not much is being written about this because it's not so much of a problem with the effective therapy that is available. So just having anti-HCV positivity is not enough to call it reactivation. Anti-HCV just tells you that the patient has been exposed at some time to hepatitis C and does not necessarily imply active infection. Unlike hepatitis B, hepatitis C does not have a CCC DNA or an RNA in the liver, in the nucleus of the liver, which is causing a relapse or recurrence of infections. So what do you need for reactivation? You need an RNA increase over a log above the baseline. So 1 0 extra in your viral load would mean this is Hep C activation. And of course, if you know that a person is anti-HCV positive, then one needs to watch the HCV RNA closely for reactivation. What about Hep C and chemotherapy? Now, the EASL, that is the European Association for Study of Liver, recommends that all patients with any malignancy, they've made it simple. The hematological societies, I guess, talk mainly of those who have hematological cancers should be screened. But here, the Liver Society says that all cancers should be screened for hepatitis C, and I don't think that's difficult. And they found that reactivation can occur in about a quarter of patients who are infected with hepatitis C and receive chemotherapy. And as I described for hepatitis B, reactivation is different from flare. Flare is reactivation, which means increase in the viral load along with the liver enzymes going up. So 11% develop a flare. For a hematological malignancy, it's about 25%. And for others, non-hematological malignancy, it's much lower at 4%. So again, those with hematological malignancies have a much higher incidence of developing a flare. And this may lead to discontinuation of life-saving chemotherapy, but often one may not stop it depending on the magnitude of the malignancy. And one can start antivirals as soon as the flare or as soon as RNA reactivation has been diagnosed. And the important thing here to remember is that DAAs often have interactions with the chemotherapy, and one has to make sure that the interactions are not there and take care of increasing or decreasing the dosage, depending on the type of interaction. Now, the DAAs are much simpler to give. They can be administered at any time before, during, or after chemotherapy in terms of safety, but it's always recommended to start them before starting the chemotherapy. Now, there are small studies which have looked at Hep C and hematological malignancies, and it was found that those who had received antiviral therapy for hepatitis C and had a hematological malignancy and were treated actually had a good response rate to almost 100% with these new oral antiviral drugs. So the response in those with a malignancy is similar to what is the response in the normal population. Now, what leads to quick eradication of chronic infection? The liver recovers, there's a reduced risk of reactivation. It allows the patient to receive more enhanced chemotherapy, which is more immunosuppressive. Patients can get into oncological clinical trials, and also reduces the risk of HCV-related hepatic and extrahepatic cancers. Cancers like NHLs, cancers like cholangiocarcinomas, pancreatic cancers have also been associated with hepatitis C. Now, this was a nice meta-analysis which looked at hepatitis C infection and non-hepatocellular malignancies, the ones which I mentioned. And here I want to highlight the B-cell non-Hodgkin lymphoma, which has a definite association. They looked at 58 studies in all of which 27 studies looked at the association of Hep C with the B cell NHL, and there was a strong correlation with the odds ratio of 3.3, thereby implying there's a definite risk of developing a B cell NHL in a patient who is infected with hepatitis C. Also, they looked at those patients who got treated for hepatitis C and the progression of the NHL, and they found that those who got treated had a much lower progression-free survival compared to those who did not get treated. So this is the implication of treating and also telling us, confirming that B cell NHL is indeed associated with hepatitis C. A little bit about immunotherapy. I guess you know much more about this than us, but basically we know that there are certain immune checkpoints on the cells, and these checkpoints prevent the T cells from damaging the body's cells or even the tumor cells in a malignancy. Now, when you, so these are various checkpoints which have been described. So you have the PD-L1, the PD-1, etc. They inhibit the T cell killing of a tumor cell. Now, when you block these checkpoints with immune checkpoint inhibitors, what happens is that the T cell can then start killing the tumor cell. So basically, they regulate the immune response by, so normally in a normal cell, in a normal body, these immune checkpoints actually prevent autoimmunity. Otherwise, the T cells would keep destroying the body's own cells. But we want these checkpoints to be inhibited when it comes to cancer. And basically, these checkpoints, once they get activated, they unleash the suppress mechanism. So the suppression of attack is unleashed and uncovered, and you have then the attack on the tumor cells. But in the bargain, what happens? So when your immunity goes up, as we said earlier, the risk of reactivation of chronic hepatitis B or C increases. And then you may have also an increased risk of immune-related adverse events like the iris. So yes, we spoke about this, and hepatotoxicity is not just related to the reactivation from viruses, but we know that immunotherapy is associated with an autoimmune type of hepatitis, which is a separate topic in itself, and a lot is being written about it. Or you can have liver involvement by a metastatic cancer. So that's the importance of knowing this and taking appropriate steps in preventing these or early diagnosis of situations like autoimmune hepatitis with immune checkpoint inhibitors. Now, this looked at immune checkpoint inhibitor related Hep B and C reactivation, 14 articles in a systematic review, looked at articles published between 2013 to 2018 over 5 years. And they found that most patients who were infected with B and C tolerated these immune checkpoint inhibitors pretty well, though there was, when you looked at hepatitis C, there was an increase in hepatitis C-related, transaminase elevation in about 30%, with about 17% having grade 3 or 4 increase in the hepatic transaminase. But this did not translate into patients' death or acute liver failure. So they were thought to be pretty safe. Except this, most of the other data is from case reports and case series and very few clinical trials. And especially in advanced HCC, now we do use immunotherapy, and therefore we need to be more alert because these patients are at a higher risk of developing liver toxicity. So I'd like to conclude by saying that when it comes to immunosuppression and hepatitis B and C, screen all cancers, all patients undergoing all types of transplants, solid or hematopoietic stem cell transplants, and all autoimmune disorders requiring immunosuppression for hepatitis B and C. Not just these two, but also the core antibody and HIV. So in general, we follow this practice that if any of the 3 viruses are positive, we would test the other 2 always, because the route of transmission of these viruses is similar. And it's not uncommon to find patients with more than 1 virus positive. patients without evidence of hepatitis B should be vaccinated. Do not forget to vaccinate them whenever you get an opportunity, preferably before immunosuppression treatment is started, or even after you've started and patient settles down. It's a good idea to immediately vaccinate them. Hepatitis B and treatment is mainly entecavir or tenofovir and should be given in all with moderate to high risk of reactivation, which we discussed. And those with lower risk can just be observed with regular DNA and ALT levels, and then SOS started on treatment. Those who are receiving CD20 antibodies should be treated for at least 12 months after stopping treatment, and others can be treated for 6 months post stopping treatment. For any hepatitis C positive with RNA positivity, and any immunosuppressive treatment, start treatment with sofosbuvir and valpatasvir given for 12 weeks. Thank you very much.
Thank you, ma'am, for that wonderful and superb lecture. This was a much needed topic for us, and I think you covered every aspect of hematology related to hepatitis B and hepatitis C, maybe Hodgkin's lymphoma, non-Hodgkin lymphoma, immunotherapy, checkpoint inhibitors, and chemotherapies. This was really much needed for all of us, ma'am, today. Thank you so much for that fabulous, fantastic lecture. And now we'll proceed for the question answer sessions with our Indian colleagues. So yes, Dr. S.P. Verma, your question, please.
Thank you, ma'am. It was a nice lecture. And at our center at King George Medical University, Lucknow, in hematology department, we face some problem with our ALL patients. So our acute lymphoblastic leukemia patient we manage on BFM 95 protocol, which includes initial 7-8 days of steroids only, and then day 8 we start with the chemotherapy. But we have seen in almost 5 to 10% of our patients that with the initial steroid of 3 or 4 days only, that is 60 mg per meter square, there is a rise in SGOT and SGPT, which is in the range of even more than 5 times, reaching up to 250, 300. And that is the time when we have to delay our chemotherapy. And for that, we have evaluated our patients, hepatitis B, C, EBV, CMV, parvo, everything, all the viral possibilities and autoimmune possibilities also. But we do not get any specific cause in these patients. So what do you think, what can be the possibility? Because, we tend to have, problems. We have to delay the chemotherapy, date chemotherapy, and we have to wait for recovery of the LFTs. So can you throw some light on that?
So you are saying they're even anti-core negative, these patients?
Ma'am, so what we routinely do is we rule out hepatitis B, HbSAg, SCV, and HIV that we do baseline itself before starting chemotherapy. But in such patients, when we have this elevation, then we go for core antibody and HBeAg also, along with HCV RNA. So we repeat these other markers also, but everything comes negative, and we do not have a specific cause for that situation.
Yeah, so what I would suggest is, and this is what we did earlier, that when you do, the moment you diagnose the malignancy, any malignancy, a moment you decide this patient needs a transplant for whatever reason, it's not only hepatitis B surface antigen, do the anti-core antibody. That's the crucial thing, because that person may have cleared the surface antigen, but has that CCC DNA in his hepatocyte, which is going to cause reactivation. And what is telling you that? The core antibody. The viral load may be negative. Your DNA and core is coming later. Let it not come later. Let it be done at the outset when you do your triple H, the B, C, and HIV. Along with that, do your core antibody, anti-HBC IgG. And the moment you find it positive, start treatment. So you will get at least a week or two before you're actually starting the chemotherapy on these patients. Do not wait for the flare to happen to do the anti-core antibody. I think that's the main thing.
Yeah, ma'am. Thank you, ma'am. And for all, patients with leukemia, where we are going to give induction chemotherapy, the initial induction chemotherapy, do you advise that for all patients we should do the panel of hepatitis B, surface antigen, SCV, and then core antibody and HBeAg? That should be done for all patients?
All, I would say all malignancies, hematological, non-hematological, just test everybody for this. Though the risk of reactivation is much more with hematological problems.
Thank you, ma'am.
Thank you, Dr. S.P. Verma. Dr. Sandeep Nimani, your question, please.
Yeah, madam. Sandeep here. Very nice lecture. Just wanted to ask you, like you have covered almost everything. Now, we hematologists face thrombocytopenia patients for fitness for surgery. And when they come to us, we diagnose them as chronic liver disease, portal hypertension, and splenomegaly. And we give fitness for the caesarean section or the surgery from our side. But when you ask them to take a gastro consultation, the gastrologist says that the patient may have high risk of decompensation, patient can land up in ICU, and patient can die of cirrhosis. But once the patient is pregnant, anyway, we have to give fitness. So how to tackle this both situation when the patient is suffering from CLD thrombocytopenia?
You're talking of pregnancy.
Everything like pregnancy, you can say, or any surgery for that matter, which is required to be done with a CLD patient.
Yeah, so there are definite guidelines. We follow what is called the MELD score. The MELD score is a score which tells us the severity of liver disease, and it is based on bilirubin, creatinine, and INR. So, depending on the severity, if you have a MELD score more than 15, we say that the risk of any surgery is very high. And then you have to really think whether so it's mostly a decompensated cirrhosis who actually needs a transplant, whether it makes sense in performing any surgery in this patient. In a MELD score of less than 10, you are okay to go ahead. Between 10 and 15, you have to weigh the risks and decide. But we use more and more of TEG in our liver patients to decide on what products to give. Because not only platelets, they also often have high, low fibrinogen, they have high INR. So, and we also know, this is a very important concept in liver disease, that in chronic liver disease, they are also prothrombotic. In fact, we are now more worried about thrombosis rather than bleed. They are prothrombotic, and therefore we use TEG as a guiding force in our liver patients to decide on the blood products, and MELD to decide on the risk of surgery. So these are the two things which we use to decide. So we may have a patient with an INR of 2.3, but you have a TEG which shows that the patient needs fibrinogen. So we give cryo and not plasma. So we are using less and less of plasma as a therapy in our patients. And because we are not being guided by the INR, we are looking at the TEG to decide what is needed for the surgery.
Thank you.
Thank you, Dr. Sandeep Nimani. Dr. Hamza Tara, your question, please.
Sure.
We are not able to hear you. Yeah.
Am I audible now?
Yes, you are audible now.
Yeah. So, thank you for the wonderful lecture, madam. My question is about hepatitis B vaccination. So, do we always have to use the anti-HBs titer to decide whether the patient should be vaccinated? And how do you proceed? If the patient has already been vaccinated before and the anti-HBs titer is low, how many doses of vaccine do you recommend?
So in those who have received, so typically, and we often see it among medicos, that people have taken 2 doses, forgotten the third dose. It's very common because the third dose comes after 6 months. So if somebody has taken incomplete vaccination, we check the antibody. If it's low, give one more, we give the whole thing again. But if somebody has a low titer, has received a full vaccination, they have memory cells which can respond. Antibodies, they can respond when they are exposed to the virus. So you may make do with just one booster shot of the vaccine, and they would have. So in patients, especially with low immunity, like our chronic liver disease patients, any patient, I would say any of your malignancy patients, renal patients on dialysis, these are patients who do not seroconvert very easily to anti-HBs. So in these patients, so immune compromised patients, we would want to document 1 month after completing the course of hepatitis B vaccine, the third dose. 1 month later, we would look at the anti-HBs. And if their anti-HBs titers are not more than 10, we would like to give them a second dose, maybe at double the dose. Second course of vaccination at double the dose. Because all immunocompromised patients do not build up immunity like the immune competent patients.
Dr. Amit, can I ask one more question?
Yes, please go ahead.
Yeah, so I wanted to ask this thing, how do we approach a donor who is hepatitis B positive? So many times we have got very limited donors for transplant. And if one of the match sibling is hepatitis B positive, either a HbA or 4 antibody positive, then this thing, do we treat them before taking for transplant, or do we treat the recipient after the transplant?
No, hepatitis B definitely donor to be treated before the transplant. Before.
Okay.
And you need to have
And
a
if they
negative viral load. There should be no detected DNA before the
okay,
transplant.
okay.
Yeah. And
Thank you so
continue
much.
recipient post donation with the antiviral therapy. Preferably.
Okay, and the same rule will apply. You continue it for a year after stopping immunosuppression.
So yeah, that depends on what you're using it for. But in hematopoietic stem cell transplantation, the recommendation is to continue lifelong.
Okay. Thank you so much.
Thank you, Dr. Hamza. Dr. Gopinathan, your question, please. You're muted, Dr. Gopinathan. You're muted. Please unmute yourself. You're muted, Dr. Gopinathan. Oh no. You're still muted, Dr. Gopinathan. We cannot hear you. Can you type your question in the meanwhile? So we cannot hear you. Just please, if you can type your question in the chat box, I'll come back to you. Dr. Sujata Sharma, your question, please.
Yeah, good afternoon. It was a very nice lecture. I just want to, am I audible?
Yes, you're audible.
Yeah. So I just want to ask, like many of our patients in Sion Hospital, they're not vaccinated at all before starting chemotherapy. So in that scenario, should we give them immunoglobulin, hepatitis B immunoglobulins, and then take them, or as an prophylaxis? Initially, we used to give prophylaxis of immunoglobulins for all patients because curing from one disease and having one chronic illness was not a fair thing. So can you just put a light about giving immunoglobulins for those who are not vaccinated, or as such as a prophylaxis in before giving chemotherapy?
So immunoglobulin is not recommended. It is actually given only once person is already exposed to surface antigen or to the hepatitis B. So giving it prophylactically has no role. So like we give immunoglobulin to children born to hepatitis B positive mothers, we give immunoglobulin immediately after birth because they have been exposed. But prophylactic immunoglobulin has no role. What I would do is, I would probably, if the patient has not been vaccinated, does not have protective titers at all, then I would probably give a double dose because you can't wait for the 6 months. Of course, there is an accelerated schedule, a very accelerated schedule of hepatitis B vaccination. 0, 7 days and 14 days. There is a schedule like that.
Yeah.
Could do that. You can wait for 14 days and finish the schedule. So you could do, or you could give a double dose and in the first shot, and then it all depends on how much you can wait to start your chemotherapy. That is a crucial thing. But there is a very accelerated schedule of the hepatitis B vaccine, which one could follow.
Yeah, and we have a lot of thalassemia patients for transplant. So Hep B positive patient who's now cleared of his viral load, but then we go along with the anti-core antibodies titers to decide whether he should be taken for transplant, or just getting viral load in negative is enough. His enzymes are normal.
No, treat them like any other patient. So if the anti-core is positive and the surface antigen is negative, I would cover them with the antivirals.
So what I want to say, like during the transplant, he will undergo through a lot of severe immunosuppression. So
Yeah.
only giving entecavir would be enough, or
Yeah. Either entecavir or, see, the only situation where we do not prefer entecavir is, which you will not see much nowadays, we used to see about a decade ago, is the patient has been given lamivudine. Because if they've been given lamivudine, they have a higher risk of resistance to entecavir. It's the same group, nucleoside analog.
Okay, yeah.
If the person has not been given lamivudine, entecavir is fine. Either entecavir or tenofovir. is fine. Single drug, that's fine.
Okay, okay, that's it. Thank you.
Thank you, Dr. Sujata Sharma. Dr. Gopinathan? Dr. Gopinathan, are you able to hear us? So, oh, we cannot hear you anymore. So if you can just type your question in the chat box, that would be fine. We can't hear you. Just type your question in the chat box. So Dr. Neem, Neemya Thanda, your question, please.
Yes, thank you for your excellent lecture, madam. I'm from Myanmar. I have some questions. If the patient is high grade NHL and HCV is newly diagnosed HCV, and shall we delay and we have to start the antiviral the treatment? So should we delay immunotherapy like the rituximab? Should we delay? Should we delay that treatment?
So that depends on what you feel, what is the urgency of starting treatment. If you can wait a couple of weeks, it's always preferable from our perspective. But if that is going to cause further aggression of the malignancy and bad outcomes because of that, so it's not one short answer which I can give. It all depends on what is a bigger risk. Is the risk of flare more? And we know what are the risk factors, high risk factors for a flare, or the risk of, the malignancy progressing rapidly more. If it is possible to wait for some time, for hepatitis C, it's relatively easier and less of a problem. The problem is with hepatitis B, where we see that especially with a Ritux protocol, the chances of a severe flare are high. And one, in spite of starting treatment, because often the treatment gets started along with the immunotherapy or the chemotherapy, that in spite of that, quite a few patients do develop reactivation and serious flares, which may even lead to death. So it's both ways. I don't think we can have a definite answer for that. So I think whatever you feel is safe enough to wait for starting your therapy, you wait, and in the meantime use. So therefore I said, it is best the moment the lymphoma is diagnosed, or the moment a malignancy is diagnosed, or a moment you think the patient is likely to require a transplant, I think just get the viral markers done. Because you wait till you take the decision of starting chemo, it's going to be a couple of weeks anyway. So you could have, started the therapy earlier. So I think that's I would say the main take-home message. Test them early and do not forget to test for anticore, which is often forgotten.
Thank you. And another question is, I'd like to know role of N-acetylcysteine in case of the raised transaminase level.
No role. There's no role for N-acetylcysteine just for raised transaminases. The only role for N-acetylcysteine if the patient is in acute liver failure, which means that he has a high prothrombin time, coagulopathy, and encephalopathy, both. Only then there is some role for N-acetylcysteine, not just for raised transaminases. Or for that matter, there is no other liver tonic, like people start UDCA, and there are a whole lot of drugs in the market. None of them have any proven benefit.
Thank you. Thank you, madam.
Thank you, Dr. Thanda. Dr. Gopinathan?
Yes, sir. Right now, sorry for a small technical bit, sir. I wasn't able to hear. Ma'am, I really enjoyed your lecture. It was a very neat, clear, crystal clear presentation. I really enjoyed it. My question is regarding those children on ALL chemotherapy. The treatment goes on for 2 to 2.5 years, and in between they receive multiple blood transfusions. Most of the time, we do see them reactivating hepatitis B during maintenance phase. So if that is the scenario, how frequently, while on chemotherapy for this 2.5 years, how frequently do we need to test, ma'am? What is the frequency that you suggest that testing?
So I think initially, so you have started them on therapy right in the beginning. I think when they're going into the first, second year, by that time, the viral load should have come down. So you look at the viral loads. Initially, maybe you can do it monthly and also do the enzymes. Enzymes also give you a clue. And as you find the viral load progressively coming down, you can reduce the frequency to once in 3 months. I think that would be adequate. So you depend on how the response of the viral load is to the thing. And you may actually, just from the economic viewpoint, try and do the enzymes more often, because that will be cheaper. And you see a little bleep in the enzyme, you immediately get a viral load done, because doing a viral load so often is not cost effective often.
Thank you, Dr. Gopinathan. Dr. Sandeep Nimani, you have a question?
Yeah, ma'am, taking the discussion of vaccination forward, if patient requires immediate chemotherapy to be started and patient is not been vaccinated, can we give the vaccine today first dose and tomorrow can the chemo be started for the disease? And what about the seroconversion? Does that, like the immunosuppressive therapy will avoid the seroconversion to happen after vaccination?
Yeah, so that's a problem. Ideally, try and vaccinate when the patient is not started yet, if it is possible. And again, the same point, when you're testing the patient and you're thinking of chemo, start doing their viral markers, so that at least you can quickly start vaccinating them, and starting them on respective treatment. Yeah, but I would say that once they are on chemotherapy or any immunosuppressive drug, the chances of seroconversion will go down significantly. So maybe if you're giving one dose, you can give a double dose. That's one thing you could do. You could give a double dose. That's the best you could do if you have no choice but to start your chemotherapy immediately.
Okay.
Thank you, Dr. Sandeep Nimani. Ma'am, there are some questions from the audience. Dr. Babita Sori has raised a question regarding HBV flare when the patient is taking rituximab chemotherapy. And the question is basically, the patient develops HBV flare because of rituximab. Is it that we must stop rituximab any other further, and the rituximab should be contraindicated further?
Difficult question. Again, it's all, it needs an MDT. How important is a patient dying of the lymphoma, or the retux flare itself can be very dangerous as far as the liver is concerned. So yes, maybe if it is possible to stop it for a while, but it will all depend on the risk and benefit. How bad is the malignancy versus what is the risk of the flare? I think these two things. For example, if the viral load is very high and the patient has a flare, this is a poor prognosis as far as the liver is concerned. I may want to stop it for a while. Viral load not very high and a flare, I may want to continue the chemotherapy. It all depends on the risk factors.
Thank you, ma'am. Another question from Dr. Krishna Ratnam Kannan. If you have a patient who needs hematopoietic stem cell transplant and the donor is HBs antigen positive or anti-HBs core antibody being positive, can that donor be used for transplant, number one, and the patient is negative?
Yeah, I think we discussed that. Can be used provided the viral load is negative. So you'll have to treat the donor if the viral load is present, and continue to treat the recipient after the transplant.
Absolutely. Thank you, ma'am. Another question from Dr. S.K. Sharma. Is there any data on reactivation of hepatitis D, particularly D for Delhi, particularly in HDV co-infected patients, where it could prove disastrous?
Yeah, so fortunately for us, there's no hepatitis D in India. So forget about D. There's no hepatitis D in India. But yes, D reactivation is known to cause major flares and problems, but we don't have it in India.
Okay, thank you, ma'am. Another question. So that's all. Finish. Dr. Thanda, your question, please. You have a question? Dr. Ninmya Thanda? Yeah, I think she has no other questions, and I finished all the questions from the audience. Dr. Thanda, you have a question? So any discussion want to ask any other question to Dr. Yes, you have a question?
Finish, sir?
Yes, please go ahead.
No more questions, sir.
Okay,
No more questions, sir.
Thank you. So
Yes, can I?
You have a question?
Yes.
Please go ahead. Yes.
Madam, thank you for the excellent talk. May I know your line of management in the patient with anti-HPC, naturally occurring anti-HPS in low titer with anti-HPC IgG positive patient, and who will be given for IST therapy?
Who's being treated for what therapy?
Or have immunosuppressive therapy? Yes.
So those who are anti-co positive.
Anti-HPC co-positive IgG positive and anti-HPS naturally occurring in low titer.
Yeah, so I would still treat them with the drugs, the same antivirals, which we
Yes.
treat, anticavir or this. But
Yes.
if they have anti-HBS in a low titer, there is some degree of protection. But basically, it implies that, I mean, that's an unusual situation. So your surface antigen is negative. If they were only anti-HB, so it means that the patient has had a past infection. Basically,
Yes.
when you have anti-core and anti-HBS, may have been vaccinated also, but the fact vaccination will not give you the anti-core. It will only give you the anti-HBS, because what you
Yes.
get in a vaccine is just the surface antigen particles. But the fact that the anti-core is positive tells you that this patient has had a past infection. And if the person has had a past infection, he would have a CCC DNA in the nucleus of the hepatocytes, which means that there is a definite theoretical potential to reactivate the virus. In fact, there are patients who are just anti-HBS positive. They are not even anti-core positive. They're anti-HBS positive from a previous infection. They too can sometimes reactivate because of the core in the CCC DNA in the liver. So I think any past infection evidence, if you have, you need to treat.
Yes. Madam, where you choose that patient as a stem cell donor?
Sorry?
Where you choose that patient as a stem cell donor?
I can't get your question, sorry.
Yes, when you choose that patient like anti-HPS, positive in low titer with anti-HPC IgG positive, where you choose that patient as a donor, stem
Can
cell
you-
donor.
Yeah, I guess you can, but again, check the viral load and make sure that the viral load is negative before you choose that person as a donor.
Yes. Yes. Do I need to give recipient to antiviral treatment after getting that?
Yeah. Yeah.
Yes.
Yes.
Yes. Next question, ma'am. When you choose stem cell donor and recently treated ACV, hepatitis C.
Yeah, you can. Same thing. You'll treat the donor. You'll treat
Yes.
either the donor. You preferably treat the donor if it's possible, or treat the recipient if it's not possible to treat the donor and the RNA is still there. You would probably want to get the RNA negative in the donor, but in case you're not able to get an RNA negative, so that's the difference. In a hepatitis B, you want the DNA negative. But in a hepatitis C, even if the RNA is positive, you could still transplant and treat the recipient.
Yes. Thank you so much.
Thank you. So there are no more questions from the audience and there are no more raising signs. Well, ma'am, thank you so much for that wonderful, fabulous lecture and what a wonderful question answer sessions.
Yeah,
We
that was fun.
learned a lot from you, especially regarding the donor being positive and you need to treat the recipient even if they are negative. Thank you so much for a wonderful lecture, fabulous, fantastic lecture, great learning and a wonderful discussion. And I think all our discussants to join here as well as all our audience to participate in this webinar. Meet you next week, next Saturday, Sunday with another beautiful webinars. Thank you so much, ma'am. Thank you once again, all the discussants and the audience. Bye. Goodbye for now.
Bye. Thank you.